Okay, καλημέρα σε όλους και από μένα. Ετοίμασα αυτή την ομιλία στα αγγλικά, συνεπώς είναι στα αγγλικά. Mr. Chairman, I'm very grateful to you, to the Demiri, and to the Special Unit for Biomedical Research to be here today. Thank you also to the organizing committee for giving me this opportunity. I have no financial or other disclosure, but I have a confession to make. It took me 25 plus years to be here to plant that seed in this country. I remind you that this is the month of craniofacial differences in another country of the world. And the objective of this talk is to present to you a referral center for craniofacial differences and also to argue the case for teamwork in order to achieve the best clinical outcomes. So let me give you an overview of what we're going to talk about. This is what we're aiming at, how we're going to apply this, what's the approach we're going to take, the innovation this is going to break in, how we're going to get organized about it, and if we have some clinical applications, healthcare burden, and clinical indicators that come with that. The Craniofacial Center mission is twofold. One is absolutely essential. It's create a registry, a formal registry of this condition. Without it, we don't go anywhere. And the second one is to provide and define clear treatment pathways for these conditions. It aims at institute a national database, establish and deliver MDTs, educational transfer, connection of primary, secondary, and tertiary public and private healthcare providers to a single center, expand focused research, develop a service-centered healthcare infrastructure, design further activities and collaborations, and very importantly, inform the public at large and the medical community of our presence. Because believe it or not, they don't know we're here. Application of it will be through two different programs. One is aiming at cleft lip and palate, and the second one at craniofacial differences. The approach we'll take, we will see all congenital or acquired conditions, be it cleft lip and palate or craniosynostosis and any other craniofacial visible differences, anything, sorry. The MDT team will see and treat function and appearance of these patients, and all patients, adults and children, will receive a comprehensive, specialized, multidisciplinary care. Where is innovation in that? Well, the center will be the first national craniofacial difference referral center and a model unit to be established in a public healthcare structure in Greece, first time. How are we going to get organized? And I'm very grateful again to the unit for giving us this opportunity. It will be under the roof of the Special Unit for Biomedical Research, who is subdivided in 4 different ones, under the head of Professor Riadis, who is the head of this unit. The administrative governance will be of Demiri, the Professor of Plastic Surgery and head of the department. The scientific and lead of this unit will be the presenter. And of course, we'll have a scientific committee formed by plastic surgeons, ENT surgeons, pediatricians, and a neurosurgeon. And last but not least, there will be a coordinator who will also assume the role of administrative secretary of the center. It will function on a multidisciplinary and interdepartmental basis, with a team leader, with team members, in a crystal mark environment, respecting equality, diversity, and human rights, using healthcare key performance indicators, patient-related outcome measures, patient-related experience measures, and working in transparency with no hidden agenda and hopefully no bullying. And of course, we set an example for the next generation. Let me just present to you what the craniofacial team looks like. Well, all these people involved here. A plastic surgeon with a special interest in craniofacial surgery, an ENT, oral max-fac surgeon, neurosurgeon, oculoplastic surgeon, neonatologist and pediatrician, a geneticist, orthodontist or pediatric dentist, anesthetist, a pediatric cardiologist, and a pediatric surgeon where he or she is needed. But there are also other healthcare professionals that are involved. This is a clinical team coordinator who is absolutely essential, a craniofacial nurse, absolutely essential as well, physiotherapists, audiologists, OTs, social worker, physiotherapists, radiologists, social services, speech therapists, medical imaging, very important, and medical information technology specialists, also very, very important. But let me just illustrate what we do. Well, who are we? I mean, we're just medical health professionals, and we do have a certain amount of knowledge in us. We have special skills, and we do have an attitude. This paper here, which I commend to you, groups it all under one paper. But we have to practice what we preach, and craniofacial surgery is a plastic surgery subspecialty that deals with congenital and acquired deformities or differences of the head, skull, face, neck, jaws, and all associated structures. So it's not tissue specific. And it's way beyond our skin. It's more than skin deep. And there is a meeting point. And that meeting point is the crossroad of collaborations. And yes, there are big chiefs in that. Big egos, very big egos. There is a key to it though, and there is also a maestro. And that is the meeting point. It sits right in the middle of our head. This is where all our specialties meet. ENT, neurosurgeon, plastic surgeons, you name it. And this is the big whites. The ethmoid and the sphenoid. No one else. Big egos. But the key to them, you see them here, is here, is the vomerine bone. If you unlock it, you've unlocked the splutocranium from the cranium. And of course, there's a big maestro in the development, and that is the trigeminal nerve. Now, let me just remind you that the term craniofacial anomaly is just obsolete. We're talking about differences anymore from now on. And what is a difference? It's a medical condition that may or may not be present at birth and differs significantly from the usual or the common anatomy and function of the human body. It may be congenital, or it may be acquired, but it needs surgical intervention. They don't also need surgical intervention, they also need psychosocial intervention, these people. What do we see in plastic surgery? Well, we see mainly cleft lip and palate and craniosynostosis. But that brings me to the next topic of my speech. How do you feel about your face? Well, I'm not a good one to talk about it, but these people are. Instead of staring, be kind. That's what they say. Does your face really represent who you are? Well, I'm inviting you to meet C, and you will have a surprise very soon. C, on a sunny Saturday afternoon, as we were having coffee, told me, it's not the 50+ operations I had that bothered me. It's the gazing, verbal and non-verbal rudeness of people. And more soon. I'll give you just a few clinical examples. Craniosynostosis are dealt with in a team fashion. This is an endoscopic right coronal pseudosynostosis treated. This is a scaphocephaly treated again with a team approach. This is closer to our microsurgical world. A case of scleroderma dealt with by an anterolateral thigh flap. And frankly, I don't think you can beat that smile. No, you can't. And that brings me to the clefts, which are a fairly common condition. And we have a variety of operations to deal with, and a few clinical examples here. A unilateral cleft, here another one. And of course, this is a presentation that are meant at a meeting because they are the best. But you will see soon something that is not the best. Another case here. And another one. A bilateral case, another bilateral in which we use taping. A syndrome, von der Woude syndrome. And another case, a quite severe bilateral complete cleft lip and palate, and that was closed directly. And you will see the difference with that guy here. And I'm pointing out here at this little device that you see here. That device is a NAM, is a nasoalveolar molding device. And with that, you can achieve things that you will compare here. You see the postoperative difference between the one and the two. There's another one here, using the NAM device. But it's not only about primary surgery, it's also about secondary revisions. And there's a secondary lip revision you see here, a little bit of cartilage grafting and lip revision, more cartilage grafting. And this young lady was unhappy with her scars and her lip, so we put a little fat graft in to make things better for her. This young lady here was unhappy about her scar on her lip. She wasn't saying anything about her dentition or her nose, so be it. But it's not all hunky-dory. And I will present to you the first three cases that was presented when I landed in this country. That's the first case. Not ideal. The second one. And the third one. That was my welcome present. But we can have complex problems as well. This is a lady in a CT reconstruction of a lady with alveolar cleft that was left untreated. And what he did for her, we went and looked at what the cleft was like. Then we went and prepared the facial vessels, prepared a DCA flap that we took into place, and this is her earlier postoperative result. But this is not just about looks. How do we measure outcomes? Well, we measure speech. And speech equals velopharyngeal competence or dysfunction. It all carries a burden too, and this has been documented, it's been calculated and what have you, but this is way out of this talk. But let me ask you a question. Would you treat these patients on your own? Well, the answer is no. Why? Because we have teams. And if we have teams, it's for one simple reason, to achieve the best possible outcomes for these patients. And because working as a team provides measurable quality outcomes. So the team approach is nowadays standard of care. And if you travel to America, then, and if you want to treat patients with clefts, then you have to apply for standard of care. Let me give you an example of what that means. That means that in a linear fashion for cleft lip and palate, for example, you will see a patient or the family of the patient in an antenatal clinic. Then you will have to use an AM or not, proceed to a cleft lip and palate repair, then proceed with speech therapy if needed, and then do any revision before that kid goes to school. Then you're going to leave that kid alone until the canine starts coming down. That child will need a bone graft, and then we leave him again alone until later adolescence when the facial growth has finalized. In all that line, you will note that the pediatrician is present at all times, and also the dentist is present at all times. So it is a matter of multidisciplinary teamwork. But how do we measure outcomes? We measure them with clinical indicators, with patient-related outcome, with patients-reported outcomes, and with cost analysis. I will not bother you with the rest of it, but there are advantages, and there is a future to it. And this is where we live now, in a mixed reality, which is the real environment and the virtual reality. And we make full use of that, believe me. What's the future for training? Here it is, neuroplastic surgery. That's a new innovation. It's been described a few years ago, but it is here. So, welcome to utopia. But utopia is where progress takes shape. And without proceeding to questions, I would like to introduce you and please welcome C, who is present with us and who will share with us what his experience of craniofacial differences are, what his experience of our world is to him, and what he endured through his livelihood until now. Please welcome Christian.
Good morning, everyone. My wife and I are very happy to be here today. I'm very grateful to Professor Foroglou for this opportunity to speak to you all. To give you a very brief account of my story, I was born in London in 1984 with severe craniofacial anomalies, including but not limited to a bilateral cleft lip and palate, craniosynostosis, hypertelorism, hydrocephalus, and profound hearing loss. My first major operation took place at Great Ormond Street in 1985 to alleviate the pressure on my brain. My parents were told that only major craniofacial intervention would suffice for my general well-being, which resulted in a meeting with Dr. Paul Tessier, the father of craniofacial surgery. In 1993, Dr. Tessier performed a highly risky but necessary operation, which laid the foundation for my future reconstructive surgeries. I then had a couple of smaller surgeries, including a Lafore 1 procedure, and years later that was followed by the challenge of reconstructing my nose in Chicago in 2002, all of which were performed by Dr. Gary Blackett and Dr. Robert Walton over a series of around 15 operations. The technique used was the paramedium forehead flap procedure. Because my midface did not have the required space to build a nose of normal proportions, the first stage involved a skin graft taken from my forearm to effectively push my top lip downwards and create the required space. The next major stage was the reconstruction of a new nose. Cartilage, which amounted to an entire rib, was used for the framework, and the forehead flap was then used as new skin. My final major operation took place in Los Angeles in 2005 and was performed by Dr. Henry Kawamoto. This involved bringing my hairline and eyebrows, which were abnormally high, down to a more normal level, and the technique used for this was tissue expansion. All in all, I underwent a total of over 50 reconstructive surgeries. While going through all this, my family and I were quite isolated, especially in the early years, as there were virtually no organizations around to offer any emotional support. Nowadays, there are thankfully many of them all over the world. This has helped immensely in raising awareness, and it has also helped in recognizing that the psychological challenges of living with facial differences are almost as important as the physical ones. The unpleasant experiences I would sometimes encounter during my childhood can still happen to a child today. Only education, awareness, and understanding will eradicate this attitude. Since moving to Greece, I have become determined to do my bit in raising awareness here and to be a voice for adults and children living with facial differences. I'm proud to have become involved with several organizations over the years in the UK and the US, More recently, I visited the Craniofacial Center in Athens, founded by the late Dr. Triaridis. I believe that it is the only private center in Greece which deals with craniofacial cases, and that is where the issue lies in terms of a lack of awareness in this country, and we must do more to change this. Sometimes you have to go on the path which will be littered with hardship in order to reach your goals. In my case, it took me some time. I do not wish to create the illusion that I have overcome everything, as we all have our insecurities. But I do feel proud to stand here today as someone who has been there and done it with the strong determination to make a small difference to any adult or child who may be in the situation I was once in. Thank you very much.
Thank you very much for sharing your experience with us, which highlights the importance of the establishment of a National Referral Center. Κλείνοντας, θα έχουμε την τιμή